So welcome, ladies and gentlemen, to this, the first board of calendar 2021 of the George Eliot. Just before we get going on the main business of the board, and we do have a very full agenda today, I did want to say a few words regarding an ex-colleague and ex-director of nursing, Michelle Norton, who has sadly passed away recently. Michelle trained as a nurse at Birmingham City Hospital, qualifying in 1992, and worked clinically across a number of roles at the George Eliot, gaining promotion and experience in a range of disciplines. She joined in 2007 Worcester Acute Hospital as Deputy Director of Nursing, and following this spent some time working for the then regulator, the TDA, which is now NHS Improvement. She joined the George Eliot as its Director of Nursing in 2015 and was known for her compassion and caring in that role. She was a very popular colleague. A number of us knew her and brought a great deal of energy and positivity to the George Eliot. But after a period of ill health, she retired in November 2018. Michelle's legacy lives on in all those who knew her and worked with her and were inspired by her. And so our thoughts are with her family, friends, and colleagues at this very difficult time. And Michelle was an inspiration. And during this third COVID peak, I just want to put on record my thanks as chair and all of the board's thanks to the phenomenal efforts of our colleagues in the trust and working in the community. Our colleagues pay an enormous personal price for their phenomenal efforts to look after the citizens that we serve, and their families have made enormous sacrifices over the last year. We can't thank them enough. But to thank is very important. So on behalf of the whole board, thank you for your day in, day out commitment, for the burdens that you take home with you, and for the support of your families at this time. Thank you very, very much. So moving forward then, I think we've got 37 items on today's board. It is a very full board, so I will, as ever, try and keep things moving at an appropriate pace. So any new declarations of interest from colleagues? Please raise your hands if there are. Okie dokie. So the last set of minutes, was everyone happy with the last set of minutes from the 1st of December? Okay, please raise your hand if you're not happy, otherwise I will sign them in due course. Thank you. So we'll then go to matters arising, which are on page 19 of the pack. The first was for the Executive Risk Committee to be reflecting the maternity risk management structure, and that was now done. Thank you, Daljit. And then also to discuss the UOR audit outcomes and action plans. That's on the agenda today, Daljit, so we'll come back to that. Thank you. And then on the Freedom to Speak Up staff evaluation feedback to be included in future reports, that will be seen at the next report, which is to be seen on the 21st of March. Then some older ones. First of all, a breakdown to be provided showing staff group and ethnicities for cohorts 1 to 3 of the leadership programme. Gertie, where are we with this, please?
Yeah, we'd originally set out, Chair, that this would go into the IPR, but as we've agreed, the IPR will be slimmed back, taking account of the COVID pressures and winter pressures. I do have a verbal update for the board, which I will give in very brief detail, which is that we've gone through and analysed the first 3 cohorts. There's a 27% BAME and 63% white Irish or white British. We've a really good spread across all age ranges from 26 through to the up to 65 age range bracket. The male to female split is representative of the organisation, so it's 65-35 in favour of female, and we've got a good coverage across all staff groups. So it does look like it's picking up all areas and all staff. But I am happy to provide further details, perhaps maybe through the QAC going forward, if that feels like it's a helpful review, maybe on a 6 monthly or an annual basis.
That sounds a great idea. Thank you, Gertie. We'll do that. Thank you. The next issue was on the Ochandon Report, and the Quality Assurance Committee received a response to that in January. And then a wider report is going to come back in due course, Darjit. That's correct, isn't it?
Correct, Chair. The wider report is regarding the Women's and Children's Directorate in general and not just maternity.
Super, thank you. And then Dr. Foster's presentation to be scheduled for the May workshop. Looking forward to that, Catherine. Thank you. And then the outcomes from the Maternity, Acuity and Dependency review. That's on the agenda, so look forward to that later. Thank you, Darjit. And then an update on the STAR board expected outcomes. Glenn, verbal update on this, please.
Yes, so the STAR board work stream looking at the way the Midlands NHS is run has now concluded its work, and a recommendation report has gone through to the regional leadership team. That's not yet in the public domain because they need to consider whether they adopt all the recommendations, but as soon as it is, I'll gladly share it. It's very, very consistent with the ICS legislation that I'll be talking about in a moment in my Chief Exec's report.
Thank you, Glenn. And then on the equality, diversity and inclusion that needs to be added to the board workshop matrix for the new year. And we're coming back to that in April, so looking forward to that. Then the revised terms of reference for the new MPC to come to the board, that's on the agenda, so we'll come back to that later. And then Darjit to keep the board updated on progress regarding the safeguarding children doctor role. Anything you want to add to the matters arising notes here, Darjit?
No, just to say the delay's been because the locum doctor has been off, but it is being actively pursued and all risks are mitigated.
Super, thank you very much. And then on the FPC to get an understanding of flow data, Stephen, where are we with this?
Yeah, so we had a workshop scheduled, but given the current pressures, Anil agreed that we could send some slides around, so I can confirm the directorate are doing that this week.
Okay, super, thank you. Great. When executive directors come on the line, if you could turn your videos on, that would be great. It just allows members of the public to see us all in our full glory. And then new requirements regarding potential changes to the current FPPT arrangements. That's deferred until further notice, so we'll come back to that in due course. And then the issue on the SATH maternity report, which relates to the Ochandon report, I think we've covered off, Darjit, unless you wanted to add something else.
No, that's correct, Chair. Thank you.
Super. Are there any matters arising that I've missed? Please raise your hand if there are. Okay, team, so we'll therefore move on to the Chief Executive's report, including the COVID-19 update. Glenn, please.
Yeah, so I noted your comments about the size of the board pack and the agenda items, Chairman, so I'll be as brief as I can be. But I've got quite a big report in there today. I mean, firstly, I start with the legislation proposals that were consulted on just prior to Christmas, and actually that consultation has concluded now. As you can see from our report, that we welcome the changes that are outlined there. It would mark a move towards further collaboration away from competition, and much of what you see in that legislation actually is very, very consistent with the strategy that we've adopted as an organisation over the last few years, and indeed that we have across the group, which is about developing lead provider at place and being responsible for population health management and integration. And it's really great to see the focus that is given to place in that national legislation. I'm very pleased that I was able to help shape that, because it really will move us forward in terms of progression of our strategy. So we'll see much more on this over the coming year. What I've seen of the feedback from the legislation is there is a huge amount of support for it. So I expect that to be going through a bill through its process through Parliament over the coming months. The intention of which is to get some legislation in place that's operative from April 22. But there is no reason why we can't start to make some progress towards it. And indeed, as I referred to earlier, the Midlands Star Board has been giving some thought to that, and the recommendations from that group will help to form an implementation plan for it. There are two options within the legislation. One is to continue to have integrated care system as a board without necessarily the grip that would come from option 2, which is to have it as an independent body. And I think the independent body is probably worth emphasising here. A lot of what we've done in system so far has not had that independence, and therefore option 2 is highly likely to be the one that is preferred. The other note of caution I would put alongside the legislation is, as we move away from payment by results in the acute sector into a capitation-based funding methodology, and I do support that, we shouldn't lose the grip that we've had of cost of delivery in the acute setting through tariff. So I think things like getting it right first time, the model hospital data, we should continue to do that, and I know we will. And indeed, we met as group strategy committee last week and discussed how we were going to do more of that. So I'm sure we'll update more as the formal responses come back to that, but it's an important change for the future. There's then a list of the staff long service awards, the 40-year individuals there listed, and there's a fair few of them, plus another 62 for 30 years, another 132 for 20 years. I did ask for a list in the report, but it would have added many more pages. But it's great to see that level of dedication that we have. Many of these staff have not only been in the NHS for all those years, they've actually been in George Eliot for all those years. Then an update on testing. Main thrust at the moment is to try and improve rapid testing access, but testing is in a much better place than it was certainly last time I reported to board. There's then an update on COVID vaccination, and great work from Gertie and from Catherine, who's been last time. It's nice to see her today without a vaccine in her hand, because she's been busy giving those out to very many staff over the last few weeks, and we've got a very high take-up of our NHS staff, and obviously helping the system with vaccination of other social care workers and NHS staff, as well as the other cohorts in that first group. And as board members will know, the NHS intends to have vaccinated the vast majority of those top 4 cohorts by the time we get to mid-February. Then there's a report on critical care capacity. Part of this report is to talk about where we are today with COVID. We've seen a reduction in cases in the community over the last couple of weeks, which has been positive. That has translated through to a reduction in hospital cases, which is really good to see. The end of that process is a reduction in critical care capacity and a reduction in mortality. Critical care, though, is still pressured. And what we've been doing across the Midlands is helping to decompress Birmingham at times, but also helping to decompress London with cases coming back into the Midlands. And we've been asked to stand up to 175 or 200% capacity of critical care. And the infrastructure, the kit to do that is relatively straightforward. The hardest bit is to ensure that we've got sufficient staff to be able to run those additional beds. And it's great to see the amount of flexibility that all of our staff have applied to allow us to do that, which has led to us not being able to do all the elective work that we'd like to, because theatre staff are generally those that we ask to help us with the critical care surge. But that's been a good story in terms of our response to help the wider NHS. Also then I refer to an enhancement to the rumour mill. it's really important for us to think about how we can recognise the superhuman effort of our staff over the last few months. And so we've added this feature where staff can thank individuals or teams for their efforts. I think also as a board, we were all deeply moved over the last week when we saw a letter from a relative who lost both their parents at George Eliot, both cared for by the same team with incredible care and compassion. It's not easy always to share those stories with the public because they're very personal, but there are so many stories like that we should be proud of in the way that our staff have supported those individuals, often in the absence of their relatives because they're not able to visit the hospital at the moment. An update then from the Urgent and Mercy Care Directorate. Linked to that, we will also bring back very soon feedback from a national deep dive into long stay and the work that our teams have done on that over the last few months has been great. There's some improvements that we can make, and Catherine's currently looking at an action plan on that. But I think it's fair to say when the system review took place, George Eliot stood out as having made significant improvements and also recognised further improvements that it can make, and we'll gladly share that when it comes back. And then finally, at the end of the report, with David's help, because he produced the vast majority of this, which is in the appendix, which is to address some of the misinformation that's out there. It's been quite frustrating to see some things on social media. Firstly, the kind of COVID deniers, which quite frankly is dangerous to public health, but also this suggestion that the NHS isn't busy, which is insulting to our staff who are working incredibly hard. But COVID has had such an impact on the NHS, and indeed the way that we manage our beds, the way that we've had to cohort different patients into different parts of the hospital has made it incredibly difficult. And I think David's report really helps to explain why you can't just simply look at bed occupancy as a way of demonstrating whether we're busier or not busier. And indeed, we've demonstrated real capacity agility over the last few months to cope with those demands, and we'll continue to do so as we cope with the elective recovery which will follow. So I'm happy to take questions if that's okay, Chairman.
Thank you very much, Glenn. Very comprehensive and demonstrates the phenomenal work that the teams at the front line and around the board are undertaking. Any questions or perspectives to Glenn? Otherwise, we'll move on. Julie?
Thank you, Chair. Just very quickly, I thought the report was excellent, as well David's explanation of the impact of COVID at the end. It was great to see the transformation that's taken place in ED. There was one activity there that I really like, and I just wondered if that was being cascaded elsewhere, and that's about introducing a staff wellbeing champion, which is certainly a focus that I know the Trust want for the future. So it was just that one question, but an excellent report.
I think the notion, Julie, of a staff wellbeing champion is one I'd like to discuss further with Glenn, which I think is a great idea. I know it's being introduced elsewhere, and I'd like to find a way of us introducing across the foundation group. Glenn?
Yeah, absolutely. We had a very brief conversation, didn't we, at Group Strategy Committee about the 3 HR directors coming to the next meeting for us to, there may be 2 at that point because we're combining between Swift and George Eliot, but for them to come to the next meeting to discuss how we tackle the well-being of our staff as we hopefully exit from COVID, but also as we have to tackle what will be quite significant waiting time. So getting individuals to put themselves forward to be those coordinators in individual departments should be absolutely part of that strategy. So yes, Julie, we'll do more of it, but I think there's a lot more that we need to do, we need to think about, and indeed we'll cover in our objectives, which we're looking at in draft form later.
Thanks very much. Thanks.
Thanks, Julie. I am conscious of the time, team, so I'll move us on because there'll be lots of opportunities to discuss stuff. So we're now on to the Restoration, Recovery and Reset Programme update. Hack.
Thank you. In terms of recovery under the current circumstances, it is understandably very difficult. So since before Christmas, we've been focusing on continuing our cancer and urgent operations in terms of inpatient activities. In terms of outpatients, again, the new referral outpatient urgent attendances have carried on, and follow-ups are largely virtual anyway, so those have continued, and we've continued with diagnostics activity. So challenging circumstances, and understandably activity levels have dropped back from a recovery perspective. But it's also worth remembering the really great performance we had in terms of recovery. So we've got a really good launch pad to get going again once we are able to do so. So the focus over the last few weeks, really, I think since before Christmas, really has been on the vaccination programme, which Gertie will update on in a minute, and around managing flow of patients through the hospital, particularly from an infection control perspective, and making sure that the hospital is absolutely safe. And we've worked on some innovations and improvements there as well. So from there's a COVID virtual ward has been implemented to allow us to discharge patients more quickly and allow them to be supported at home. In terms of how we take this whole programme forward, I've always said our approach to recovery has been very much about improvement. So going forward, we'll build on that, and we'll do that through the Directorate Business and Service Development plans that we're working on at the moment, which will effectively form the Improvement Recovery Programme for directorates and specialties. We'll continue to develop our improvement capability with the QSA training, virtual QSA training continuing to be rolled out. That's our improvement training. We also continue to work with our group partners to share learning as well. And so we also recognise as part of all this work that going forwards, we'll have to manage carefully the pace of the recovery and the amount of activity we are doing, recognising that the impact the last 12 months have had on staff as well. So we're mindful of that. We're working very closely with directorates to make sure that we go at the right pace for in terms of managing the activity and the backlogs we need to manage, but also the right pace for our staff, and give staff some headroom there as well. So going forward from May, the intention is that this report will morph into an improvement report rather than a recovery report, in line with what we're expecting to happen with how we plan for next year. So I'll stop there and hand over to Gertie to give us an update on the vaccination programme.
Thank you, Hack. Gertie?
Thank you, Chair. Thank you, Hack. I'll be very brief, Chair, conscious of time. The vaccine programme at the George Eliot has been really, really successful, really positive. I'm sure colleagues will have seen the media coverage that George Eliot was one of the first to go live with AstraZeneca on the 4th of January. And since then, the clinic has built up its strengths and been running very successfully. We've now issued over 4,000 vaccines to our own staff and colleagues across health and social care. We're doing some analysis of the data because we need to cross-reference back from systems to understand exactly how many of our George Eliot staff, because staff as defined by the Green Book frontline staff is very different to what we would normally record, for example, for flu. But we approximate that we have between 65 and 89% of our staff already vaccinated. And once we've been able to triangulate the data, we will then focus on those areas if there are any, or staff groups or particular groups who have not had high take-up, and we'll continue to support colleagues as we go through. The majority of our vaccinations at the moment are local authority and social care staff, so you can see George Eliot working very closely in partnership with all our colleagues across the STP. I've no other comments, Chair, but happy to take any questions.
Thank you, Gertie. Conscious of time, any questions from colleagues on that comprehensive update from Hack and Gertie? Rebecca?
Thanks, Chair. Just to be brief, Hack, regarding the virtual ward, this is a really positive innovation to see. Just interested to hear whether we've got an evaluation strategy running alongside that activity at the moment or in the future, please.
Yeah, so similar to all our improvement work, we have a measure to improve approach. So it's continuous evaluation as we go along. So we can bring that back to a future meeting.
Excellent.
Okay, that's great. Thank you, Rebecca. And just a couple of very quick points from me. I would want members of the public to realise how the board fully appreciate the fact that in this COVID response period, we are conscious of the fact that we as an organisation and as an NHS need to get back as quickly as possible to provide the turnaround times in terms of elective work, cancer and all the other services we provide as quickly as possible. And I think Glenn used the phrase capacity agility. And I think that is going to be one of the real things for us to focus on, things like the virtual wards work as we progress in calendar 2021. It's going to be another very demanding year, but we do need to appreciate the point that you made, how our frontline staff are tired, and we're conscious as a board of the realities of that for our frontline staff, and we need to ensure that they have time to recover whilst we do what we need to do for the citizens that we serve. Okay, team, we'll move on then. Thank you, Hack and Gertie. On to the George Eliot planning framework for the fiscal year ahead. Jenny, we've obviously had a chance to review the paper. Anything you particularly wanted to emphasise?
Just 4 quick points. One, to indicate that obviously the guidance hasn't yet been released, but we are working with the phase 3 and phase 4 assumptions. The second point is that we are building and linking in the development plans linked to the clinical strategy, so that will link with the national planning framework, but also our local aspirations that have been identified through our engagement. And the third point is that we've put in place a planning oversight group to help support and oversee the process of the planning. And the fourth point is that we've got the timetable, but that could be subject to change, obviously rating the national guidance. Those would be the 4 points I'd like to just pull out.
Thank you very much, Jenny. Questions or perspectives, Glenn?
Just to emphasise that, as Jenny says in the report, that we're still in a bit of a transition period with the end of COVID, and some national arrangements will be in place for the first quarter of next year. That won't stop us coming up with a set of corporate objectives, and we're having a look at those later in draft form in our private board, but they should come back to next month's board. So they're probably worth adding, Jenny, to the milestones at the back, that we'll hopefully be signing those off next month at board.
No, that's great, Glenn. And we've had great success in the past, for example, on the 10-point plan. The simplicity and straightforwardness of those went down, across the organisation in a readily digestible form. So I think we need to learn from that. And Glynis?
Thank you, Chair. I just wanted to ask, apologies, I can't put my camera on. I just wanted to ask about how we were going to get staff engagement. I appreciate how difficult it is to get staff involved in a planning process when they're really focused on delivery at front line. But one of the things that was key last year was that they felt that they were engaged and actually owned the plans. So it's just having a slight mindfulness that without the staff engagement, that making sure these plans are actually owned by them.
Yeah, so
David, is there anything, Jenny? I was going to invite David to sort of give a perspective on that. David Ochandon.
Yeah, I can give a perspective. Jenny has led a number of pieces of work around engagement with Catherine, particularly through development of the clinical strategy, and a lot of the engagement work that flows through into both the planning framework that's set here, and also into the way that objectives are being developed, uses the same set of intelligence that was collected through those engagement events as the clinical strategy was being developed. Jenny, would you like to add to that?
That was the point that I was going to make, David. So, and just to say that obviously the work that we're doing with the directorates through the service development plans are directly linked to the first year deliverables that have been identified as the ambitions that link to the clinical strategy, which is obviously a broader time frame. So we've got a good place to build on that engagement that we'd already done at the earlier part of the year, and it builds on that as a golden thread with both.
Thank you. And Glenn, finally.
Yeah, one thing that reassured me on that was that David and Catherine and I recently attended the Medical Advisory Committee, which is the consultant body meeting, and they're never shy to tell us how they feel about involvement and engagement on these things, and they were incredibly positive about being listened to about some of the priorities for the organisation. So that was good to hear.
Yeah. I think without sort of labouring the point, just going back on my point on the 10-point plan, it is why I think the simplicity of our objectives is really important, that everyone in the organisation can almost readily understand them and buy into them, as well as the process of involvement. Okay, colleagues, happy to move on. Thank you. Then on to the report on safe nursing and midwifery staffing. Daljit.
Thank you very much, Chair. I'll take the report as read. The key things I really want to bring to the board's attention is that you will have noted that in December and the early part of January, the staffing levels have been quite challenged on many of the wards where we've not been able to deliver the funded nurse to bed ratios consistently throughout that period. In addition to that, you will see in the ITU has definitely been impacted in this second wave, which is fairly in line with the national picture, and we've been running around about sort of 300% of funded activity. The reasons for the staffing concerns have been highlighted in the report in terms of staff isolating, staff being off, but also just to bring to the board's attention that Christmas and New Year is traditionally very difficult to fill shifts through bank and agency, so we experienced that as well. The report highlights that our numbers on some occasions have extended to one registered nurse to 15 patients, but again, to bring to the board's attention that at the beginning of the year, we actually did a risk assessment with some action cards, so we were able to utilise those to ensure that we put extra healthcare assistance on those shifts so we could continue to provide essential care, but also prioritised the care for the patients so they got the care that they required. I'm pleased to say that picture has started to improve as we got throughout January, and our staffing levels are starting to look better again. But I guess, as we've already talked about how staff might be feeling, I recognise the impact on the morale of staff when nurses feel that they're not able to work fully to the standards that they would like to. The assurance I provide to the board is that we've not had any, whilst we've had 2 red flags reported, there have been no direct correlation of any patient safety incidents as a result of this. So I've personally been meeting with the matrons on a weekly basis and the ward managers every 2 weeks virtually, just to speak to them and to ensure that they are feeling okay, and emphasising the wellbeing support that's available across the trust, which Gertie has on many occasions described to the board around trim. And we've also more recently been able to get some bespoke support from CWPT via a clinical psychologist, actually setting up some sessions for some of the red area wards and for ITU. Additional diligence has been implemented to ensure that we can enhance the reporting on a daily basis and support the assessment of risk and mitigation, and ensure that DATEX aligns to the concerns that staff are facing. In terms of vacancies, you can see in the report that there are some ward areas that continue to have higher levels of vacancy. We had a recruitment day on the 22nd of January and those continue. And on a daily basis, we mitigate those risks by moving staff across the hospital to ensure that the risk is equally carried across all areas. And happy to take any questions.
Thank you very much, Daljit. Questions or perspectives? David, first of all.
So clearly there's some difficult decisions that people are having to make on the ground, and we know that a number of our professionally registered colleagues have at times felt concerned around professional registration and the impact personally on them of making some of these decisions. We wrote to people a few weeks ago just assuring them that we would provide top cover at board level around those things, and I just want to make an explicit connection between what Daljit has said in terms of that top cover the acceptance of risk by executive directors on behalf of the board, and the reporting of the management of that risk into the board in the form of this paper and the conversation we're having.
No, thank you very much, David. And just as chair of the board, I just want to put on record my recognition of the difficult decisions executive colleagues are having to make during this period, and teams down the line, and you have my total and full support. Glenn?
Yeah, and of course we're not alone in making those decisions. The critical care expansion that David just referred to came with a national instruction that we could vary the ratio, which obviously is one thing to write down, but another challenging thing for staff to do. I think I would be reassured by the performance that we've seen over this period. I mean, there was a recent analysis by the Health Service Journal that showed the number of nosocomial infections at George Eliot was one of the best performing in the NHS, which is testimony to the efforts of the staff. The only thing I'd just caveat on this, Delta, is in section 5 we referred to a further acuity review during January. I mean, the relevance of an acuity review at the moment in terms of the activity we're seeing, I wouldn't spend too much time on using it to judge what we may need moving forward, because these are unprecedented times.
Yeah, absolutely agree with you, Glenn, because a number of organisations are not doing the acuity review, but we're continuing because we're encouraging our staff to use the safe care modules that we've set up as well. So part of that's a professional judgment element as well.
Fantastic. And final point, Glynis, please.
Thank you, Chair. I just want to thank Daljit for a very honest report. I think it's really important that we're cited on the challenges around workforce and the risks associated with them. But personally, I take a high degree of assurance about the oversight that Daljit's got in place regarding staffing and the actions that she's taking to mitigate them. So I just wanted to make that point.
Thank you,
Glynis. And as chair of Quality and Assurance Committee, that's very helpful. I'm sorry to be having to move things at pace, guys, but we do, as I've said, have an enormous agenda. So we'll therefore move on to the Maternity, Acuity and Dependency review. Daljit, anything you particularly like to pull out here?
Yeah, I think I just really want to pull out that the report highlights that the last time that the full birth rate plus review was done, which was a couple of years ago, and that historically the understanding nationally is that it's only requires to be done 3 yearly. However, I think with the more recent focus on maternity, it is recognised that that's not sufficient, and that we need to ensure that our local context triggers these reviews. So we've decided that we will do a routine review 6 monthly in line with the reviews we do for our other ward areas, so that the board will receive that assurance. But clearly, if we feel that it needs to be done in between that, we will do. So essentially what the report is pulling out, what's come out of the birth rate plus, is that there's a requirement for additional 6.6 whole-time equivalent registered midwives. And in addition, I just want to highlight to the board, we've got 2 posts which will also require funding sometime in the future substantively, as they're funded by the local maternity service, and that's system, and that's the perinatal education midwife and the public health team midwife. But also to acknowledge at the board that last year the trust made significant investment in a number of senior roles in maternity, which included a governance role, a lead for continuity of carer and bereavement midwife. So the next steps will be for the directorate to take a business case to trust management board.
Thank you, Daljit. Questions and perspectives, Glynis? Is that a historical hand up, or have you got a question?
Apologies, that's the legacy hand.
Okay, thank you. Okay, Daljit, thank you. Clearly, please keep us briefed on things as that develops. We've then got the Care Quality Commission Progress and Preparedness update. Just verbally to note this, Daljit, given the current circumstances.
Yeah, thank you, Chair. Clearly, there's been very limited CQC activity due to COVID. The formal quality governance meetings that we have with the leads have been stepped down, and our team continue to work with the directorates as they are able to support doing that given the current pressures. I continue to meet with the CQC lead on a monthly basis and review any queries or exceptions that are escalated to us, and we're looking forward to hearing about when we're due to get our new transitional regulatory approach monthly call, but there's very little to add on that.
Okay, thank you, Darjit. Colleagues, happy to move on? And then we've got the assurance report following the Ochandon report. Darjit, this work was done earlier and, as we said, went to QAC. Good to see you, Lawrence, with us as well. So how do you want to handle this? Darjit, you're on mute.
I'm happy to hand over this to Gary. Sorry.
Okay, thanks, Darjit. Hopefully Darjit will support me through this. Thanks, Chair. Thank you for inviting me to talk to this. I'd just like to acknowledge the work that that Claire, our Head of Midwifery, has put into this report. This comes about as I'm sure you're aware that the requirement for CEOs and boards to give assurance around the Ochandon Report on the 7 immediate and essential actions. This is a paper really that looks at the process that we've gone through to undertake a gap analysis, to look at those gaps and to try to address those, and then to assure the board around our compliance in all of those specific areas. There are undoubtedly going to be more refinements as the Ochandon Report gains momentum. I suspect we will see letters and further requirements for us to comply with. But on the basis of what's been provided to date, we've looked at those 7 immediate and essential actions. Those distill down to 12 urgent clinical priorities, and within that there are subdivisions as well. So the whole report actually goes through those headings one by one. We have reviewed, I know the compliance is either compliant because we've got things in place already and we've had them for some time. They're compliant because we've put them in place, or they were going to be compliant by the end of January because we were going to put them in place. We've done the assessment at the end of January and we can confidently say that we feel that we're compliant in all of those areas. We have a requirement to submit our assurance tool by the 15th of February. That assurance tool mirrors the report that you see in front of you, so we'll be able to assess that as being compliant too. I guess I don't quite know how you want to play it, but I suppose I would probably point out my areas where I have some concerns around the report. One would really be the definition of the consultant cover. So I suppose you'd expect me to say that. It's very clear in the report that there should be some consultant presence on the labour ward during the daytime and at night time, and there should be an organised ward round both at daytime and at night time. I've spoken to the authors of the report to try and get some clarity about what they actually mean, because it's not clear within the report. I've spoken to the Royal College, but nobody really has given me any guidance as yet. I've spoken to other trusts to see what their teams are doing, and we believe that having a 5 o'clock ward round at the end of the day complies as best we can with the requirement. I think what we'll probably need to do is revise that, and so we are already working up a business case just in case that requirement becomes more of a late in the day round. I think we'll have to construct some better audits to demonstrate our compliance in some of the areas, and I think that although we can quite categorically say we can tick a box, we need to make sure that we keep that in the forefront of our minds, to make sure that we're collecting data in order to evidence that as we move forward. And I suspect, although we've reviewed the patient information leaflets and we know that we're introducing Badgernet this year, we'll have an opportunity to make better inroads into patient information. So I think, that we've looked at Chelsea and Westminster's guidance and we think we've mirrored that, but I think there is more that we can do in order to provide more information for our patient group. I'm happy to take questions.
Gary, that's a really, sorry, Darjit, that's a really helpful summary. Thank you. And just before I go to Darjit and Catherine, one of the things that it's impressed me about the way we've reviewed and self-assessed ourselves has been the honesty with which we've done so. That for me is absolutely key in terms of the values and culture we have as an organisation, is that we are honest in our self-assessments of where we are. Really helpful. Thank you, Gary. Dajit, did you want to add something? I apologise.
Yes. No, it's fine. Thank you very much, Chair. So I just really wanted to emphasise to the board and give assurance that we have met those January deadlines and we're compliant on all those areas now, which I think it's important to emphasise. There's just one minor element, which is one I'd be keen to understand from the board, but it may be we work this through QUAC. But there's a requirement that a monthly report comes to the board regarding some indicators as a national document which gives a minimal set of indicators. Now we've already got a maternity dashboard, so I'm proposing that we look at that maternity dashboard and update it against what the national tool is saying to see if there's anything missing, so we've got a more comprehensive set of data to bring to the board. But my question was also whether the board wanted to consider this to be a piece of work we might want to do across the foundation group and have a similar dashboard from all three organisations coming to the board. So something for consideration.
Okay, that's helpful, Dajit. I would like a consistent approach across the foundation group. I think it's important for QUAC to agree it, but I want it to come to board, not to the subcommittee on that monthly cycle. So yeah. With those sort of three comments.
That's very helpful. Thank you, Chair.
That's no worries. Keeping things going. Catherine, I think your hand was up next.
Yeah, thanks, Russell. Gary, I'd be grateful if you could just keep me updated with the correspondence that you're having in regard to the consultant presence at night, because 5 p.m. doesn't quite sound like night. But again, in terms of the principles we've just talked about alignment, it would be good to understand what Y and SWIFT are doing in respect of that.
Yeah, I will do.
Absolutely. And, you know, it's one of the great things, Gary, about being part of the foundation group at George Eliot is we can share experiences and learn best practice from one another. And finally, Glenn?
Yeah, I was just going to thank Gary and team for pulling together what's a very clear and assuring report, actually, and for confirming the compliance of those issues that are flagged for the end of January. I was also going to make the point that Daljit's already made about that whilst QUAC should keep a close eye on this, I think we should ensure in the board pack that we've got some of those high-level indicators, and keeping them consistent across the foundation group will make that easier for us to ensure that we continue to be in line. This is something that there'll be a lot of attention on over the next year across the NHS, and therefore it's important that we're seen to be giving it suitable attention, and it certainly keep it at this level. That would be really helpful.
That's absolutely good. And I think one of the things, whilst Gary tries to turn his phone off, one of the other things for us to do, I think, it would be great to hear patient stories from the maternity services when we get the workshops going again, as well as some of the frontline teams. For me, one of the things that because I used to work over at Oswestry for a number of years. One of the things that always amazed me by distant observation of SATH was, you know, how were they not hearing the voice of the families? And so just making sure we cycle into our board workshop and patient stories, the voice of parents and families, I think would be a really good, healthy check, as well as the metrics coming out at board level. Gary, thanks for your hard work. Please thank everyone else involved in putting it together, and we look forward to seeing you again soon. Thank you.
Pleasure, thank you.
Okay. Thanks, Gary.
Okay, team, happy to move on to the performance section of the reports. So, the integrated performance report. Hack, are you going, or is David or is Stephen going to lead on this? David,
it's me. Yeah, I'm going to just I'm going to headline Russell, and then if there's any questions, my colleagues will help out with detailed answers. But obviously, we've covered quite a lot of performance ground through the conversation that we had in Glenn's report around COVID and a number of other conversations. So I'm just going to kind of highlight one or two things, starting with A&E performance. So reporting 84% for December against the 95% 4-hour standard. So a lower drift from the standard. In actual fact, in relative terms, we're doing okay. And if you look at the December figure of 94.1, the year-to-date figure of 94.1%, looking at the regional league table, which was just published today, and that would put us second in the region from a year-to-date perspective, and everybody else's monthly numbers kind of in the same ballpark as ours in a relative perspective. So that's a pretty good place to be. In terms of things like 12-hour breaches and over-hour ambulance delays, which have become quite important metrics through the COVID crisis, we have had a couple of 12-hour breaches which are reported here, but actually year on year, much smaller this year than in previous years. And over-hour ambulance delays is a relatively small number compared to other organisations across the region, and that reflects the work that's been done both in A&E and across the hospital to improve flow. In terms of planned care, obviously we've talked a lot about the work that we've been standing down to accommodate the more urgent work relating with the COVID crisis, and the fact that we've stood down P3 and P4 category elective work. So in the report, you can see there's a slight deterioration in December, but we should expect that to significantly worsen going forward because of the work that we've stopped doing. However, just to provide assurance that we are focused very much on making sure that we maintain our cancer performance. We have, as it stands, as of last Friday, 7 patients who are waiting longer than 104 days, which is a red line for us. One of those patients is waiting for an investigation result to come back, and 5 of those patients have plans involving other providers with particularly complex surgical requirements, and those patients in that greater than 104-day category are all being case managed, so there's a clear plan for each patient in that category. 62-day performance, the November figure, because this data is published a month behind, 81.7 against the 85% standard. We do expect that again to worsen in December, but there are 47 patients on the waiting list who are greater than 62 days as of last Friday, and again those patients are being case managed. So I quote those numbers to illustrate the fact that there is good grip on this, and while it's not where we would ideally want to be, we are all over it in terms of managing those patients through the system. And then finally, I just wanted to say something about staff absence, and again referred to in our analysis of the COVID situation, but this clearly adds a significant challenge into the mix in terms of running the hospital. So our staff absence figures are approximately twice the normal seasonal level that we would expect, and obviously that's forced us to make some decisions around where we direct resources. Daljit's reported that quite clearly in the nurse staffing report. It isn't just a nursing issue, though it's across the board, affecting all professional groups. And our priorities are clearly to keep our acute services running, and that's where we've directed our resources, supporting the front end of the hospital, ITU, HDU, and making sure that we can keep beds open for patients requiring urgent and emergency admission. Not planning to say any more. Pause there, and I and the team happy to deal with any questions that people might have.
Okay, that's great, David. Just before I invite colleagues, I think in the context of everything, the hospital, the trust, frontline teams, you as an executives have had to cope with, I think the level of operational grip and performance is commendable. I'm deeply proud of what you've been able to achieve as a team. Questions and perspectives? I would just like again to put onto record, you know, David was going into detail on the 104-day breaches on cancer. We are as a team extremely conscious of every human story behind every delay in the cancer performance in particular. And I'd really want members of the public to understand that as a board, we are doing our utmost, and I'm absolutely confident that the executives are doing their utmost to improve the performance as quickly as possible. So we'll move on then to the finance report. Hack, please.
Thank you, Chairman. So in terms of our financial position, it's improved in month. The increased COVID pressures have meant that we've spent less money on recovery than we originally planned to, and also the reduced bank and agency fill rates have also impacted the financial position, as you've already heard from Daljit earlier on. In terms of our looking forwards to the end of the financial year and our forecast, we're forecasting a deficit of just under £1 million, which is an improvement, largely because the STP have now agreed to use the recovery reserve to fund the shortfall on our block allocation, which was an error on our block income allocation to start off with. In terms of the risks, so the key risk to that position is around the non-tariff drugs, where the commissions are querying some of the numbers that we have submitted, and with the current pressures where we can't address all those queries because it needs clinical input, but the clinicians are clearly occupied in terms of managing the current pressures. So we are pushing back to the commissioners as well and asking for dispensation based on the current circumstances. So I'm reasonably confident we'll be able to manage that going forwards. The other issue I wanted to flag on the income and expenditure position is around the annual leave accrual. We've clearly got significantly more annual leave outstanding for staff than we have previously had, and according to accounting regulations, we're required to account for that as an expenditure, and that's going to be quite a significant number, but the regulators have confirmed that that won't count towards the number that our financial performance will be assessed against, even though it will be part of our bottom line financial position. In terms of capital, there still remains a risk around our COVID capital spend, which we still haven't had confirmation of funding, but I'm reasonably confident it will be funded on the basis that there's a national capital underspend, and also what we've had to do in terms of managing some of the in-year pressures. We've had to defer some capital spend to next year, which is roughly about £1 million, and the STP has also had to do that, so the capital programme for next year will be extremely tight. I'll leave it there and take any questions.
Thank you very much, Hack. Questions and perspectives, Glenn?
I think it's worth emphasising that one of the other factors in our year-to-date position is that we've undertaken a lot of elective activity as an organisation which has not received corresponding income. The national approach was decided to set that income level at STP level. And actually, when you look at our STP, George Eliot was the only trust that would have earned it in its own right. So that would have offset some of that expenditure. But unfortunately, we haven't got the income to match it. But the levels of elective activity the organisation were able to, up until this current pause, are really quite significant, which has stood us in good stead for getting access to capital for other elective initiatives, which we're talking about later.
Thank you, Glenn. And Julie?
Thanks, Chair. I just wanted to say that Audit Committee, as Hack's report says, this is a really important time to have robust governance around financial management arrangements, and Audit Committee were able to receive that assurance following an internal audit report, which I think is very important for the board to hear, and also about the strengthening and the improvement and embedding of new finance and performance monitoring arrangements. And again, I think that's important for the board to hear.
No, absolutely, Julian. As you know, because you attended the Foundation Group Strategy Subcommittee last week with Hack, we are ensuring across the Foundation Group that we understand better our underlying productivity. So as we come out of these strange times of COVID, we can assure ourselves as a board that we are absolutely maximising the performance of the organisation in a fair way to taxpayers. Any other comments to Hack? Thank you, Hack. We therefore move on to the letter of undertakings update. Hack, back with you.
Yeah, it's me again. Thank you, Chairman. So last year we had an issue in terms of a letter of undertakings with regards to our value for money audit opinion, and it was part of the reason why we got a qualified opinion on our value for money audit. But this year, but in terms of where we are with this at the moment, despite a really challenging year, as you've heard, we can demonstrate really significant improvements in terms of our A&E performance and our cancer performance, and you've heard about that throughout the meeting, and it's also set out in the appendix to this paper. In terms of financial performance, we delivered our control total last year at a break-even position, and as you've just heard, we're on track to deliver our financial targets in line with our plan for this year as well. The development of the long-term financial model was paused because of the current uncertainty around the financial framework going forward, as well as the planning framework going forward, and the backlogs and how those are going to be addressed. But prior to that, we had a trajectory that we were issued by NHSEI, and we'd confirmed as part of our initial STP plans that we could deliver that trajectory. So from that perspective, that addresses all the key issues that were raised in the undertakings letter. In terms of going forward, we are working very closely with the regulators and also with external audit to agree a new undertakings letter. We're expecting a draft within the next couple of weeks, and that'll come to hopefully the next board meeting, and the aim is to get the new undertakings letter agreed by the end of this financial year in advance of actually the audit, in which case we will, as part of that new undertakings letter, have confirmation from the regulators around the delivery against the previous undertakings as well. So that should stand us in better stead in terms of the value for money audit going forwards.
Very good, Hack. Thank you. Julie, anything you want to add on that?
I think I'd just like to add again that external audit valued the report that went to audit committee and the demonstration of the evidence, and they could see the progress that's been made. But that letter and that new undertaking letter is very important for them in terms of actually providing their opinion. I don't think we can underestimate the importance of receiving that.
Okay, great. Thank you very much, Julie. And Glenn, anything you'd like to add?
Yeah, as Del mentioned earlier, the CQC have just started a consultation on changing their approach to assessments and ratings of organisations, including the ability to change the rating of an organisation without a full inspection. That's particularly relevant to us. If you go back to that update I provided in my Chief Exec's report about the progress we've made around the A&E, particularly around recruitment of consultants, that's something that we hope they'll take another view on. And so together with NHSI's view of us, we hope to be in a much stronger place with the work that Hack's just reported on also.
Okay, great. Thank you, Glenn. Colleagues, happy to move on? Thank you, Hack, for that. And then before we've got the board assurance framework, the Q3 update, the high and extreme risks.
Yeah, that's me, Chairman. So the board assurance framework has been through its usual round of reviews, each element reviewed by the executive director who owns it and then presented to Trust Management Board, which is a slight change to the process because Executive Risk Committee was stood down as a result of our efforts to reduce the number of meetings that were in play because of COVID-19. The finance and performance aspects have been reviewed by Anil, who's taken that role as lead non-executive director as we've introduced our new finance and performance arrangements, and the report was also been to QAC. So having been through that process, it's here at board for final sign-off today.
Okay, thank you very much, David. Any questions or perspectives on those? Clinnis?
Yes, Chair, just to say that we had a robust discussion regarding this at our November meeting, as you'll see from the minutes, and we took strong assurance that all appropriate mitigations and actions are being taken.
Okay, thank you. And Anil?
Chair, thanks. Just to confirm what David said, I have reviewed it and I'm happy with that.
Okay, great, super. So on that basis, is everyone happy to sign off on that? Okay, super. Thank you very much. So we'll therefore move on to the infection prevention and control and testing sort of update. Dalgid, anything you particularly wanted to pull out on this? Dalgid, you're on mute.
Sorry. Just to advise board that this is the refreshed guidance that was issued in December, and you can see from our gap analysis, so we can assure the board that we're compliant with all the areas that's required of us. The only area I just wanted to take this opportunity to highlight to the board is that amidst the huge numbers of outbreaks that were happening in the community and in hospitals across the country in December, NHSE visited a certain number of hospitals. We received an unannounced visit in December, and I just want to point out their reason for visiting was due to the small size of our hospital and the impact that an outbreak would have, rather than them being actually concerned about our practice and some of the outbreaks that we were having. I've only just received the report yesterday, so I'm just bringing that to the board's attention. We had some very positive feedback at the time of the visit regarding, in particular, our staff's use and understanding of PPE and in the way that they delivered patient care in terms of, adequately using their PPE. There was nothing of major concern fed back. There were some small areas of improvement which we've already addressed, because there's many of them we picked up on the day and addressed them. And what I'd like to do is to take that assurance via QAC in the February meeting, and then I'm happy to bring something back to board in March when I bring the updated BAF.
Sounds fantastic, Dalgid. Any questions or perspectives to Dalgid? Okay, great. Thank you, Dalgid. Look forward to hearing the update again in March. We'll move on then to the summary of ratified policies. David.
Yes, thank you. So I chair the policy review group. As we've gone into the second wave of COVID, we made decisions to extend the deadlines of policies that were coming out of date and to stand those committees down. So essentially, we're just reporting that fact to the board. We have identified a small number of policies that require urgent review and ratification, particularly two HR policies that came to the Health and Wellbeing Committee last week and need to go through a process, and we've agreed that while we are in this process of reduced meetings, that I will take chair's action and then subsequently report through the committee when the committee reconvenes after we get through this wave of COVID. So just reporting that to the board, and a future report will pick up those loose ends I've just described.
Thank you very much, David. Any questions from colleagues? Everyone happy to take David's recommendations forward? Okay, duly endorsed. Thank you very much, David. And then our finance and performance arrangements have changed. Hack, thank you for the paper. Anything you particularly wanted to pull out here?
Nothing really. I'll just go straight to questions on it. Okay,
there's been sort of well signposted and discussed by the board over the last few months. Any questions to Hack? Please raise your hand. The only point I'd make, Hack, is I did think we talked about having a sort of a 6 monthly review. So my suggestion is we sort of pencil that in for September, given everything that's going on, and just have a review of how we all think it's going.
Okay.
Okay, super. We'll therefore move on to the subcommittee chairs update. And the first are the quality assurance committees of the 30th of November and the 25th of January. Glynis?
Thank you, Chair. I just want to point out, first of all, that our December QAC was actually stood down. That was the third week of December, and that was due to the COVID pressures. And that's the first committee meeting we've had to stand down throughout this COVID pandemic. So, and then from January, we've introduced a more streamlined approach, very similar to the one we took at the first wave. And as a result, we took 3 reports to our January meeting last week. We have the Ochandon Report, which we've discussed at today's board agenda, and I've really nothing further to add other than to our discussions. other than to say that we'll receive further detailed reviews and self-assessments and any associated action plans going forward at QAC. But also just so that board has cited that we're also undertaking an in-depth review of mortality in our maternity services over the year 2018. And that report again will come back to QAC. The second report we took at QAC was around clinical audit, and as board will be aware, the national programme was suspended in April but recommenced in Q3, and we took good assurance regarding our progress with this. The trust is performing very well. However, board should just be aware that there are a number of reviews of NICE guidelines and technology appraisals that are overdue, but again, that's due to COVID pressures, and we've got an audit action plan coming to us, being put in place so that we can ensure that we catch up with that. What the report did do is demonstrate our strong commitment to quality improvement. And finally, we have now resorted to a single quality report incorporating a number of measures, although they are reduced numbers. And just to point out things of note, that we also did a deep dive into surgical site infections, as last June it was identified we were in the 90th percentile, which in practice actually means we had 3 surgical site infections, and to assure board that one of these was misreported, so in fact there were only 2. And from those there was evidence of good learning and a clear plan in place to strengthen our prevention of surgical site infections going forward. Nothing else to add unless there's any questions.
Thank you very much, Glynis. Any questions to Glynis? Glynis and everyone involved in the Quality Assurance Committee, thank you very much for your hard work. And again, for members of staff who maybe haven't seen the non-executive directors as much as you used to pre-COVID, it's not for the lack of desire from the non-execs to be out on the wards and to visit you. It is purely because we are trying to absolutely do the right thing in terms of infection prevention and control, and staying away from unnecessary areas of risk. But you're very much in our thoughts as ever, and we're finding different ways of working to do what we need to. We therefore move on to the Audit Committee of the 26th of January. Obviously, we've got your report, Julie. Anything you'd like to particularly pull out?
No, I just wanted to actually say I think it is important to celebrate success, and one of the couple of the things that we do at Audit is to actually have post-implementation audit reviews, and we looked at discharge arrangements and falls this time, and what we could really see was sustained improvement. There was a lot of hard work, a lot of initiatives going into that, so I just wanted to point those 2 things out because I think it's important. Also, there's an appendix to my report around the use of resources. We are proposing, just want your agreement as a board, that we actually continue to monitor the use of resources with Anil, who's actually on the Audit Committee, through the Audit Committee.
Okay, well, that sounds entirely sensible to me, Julie. Any other questions or perspectives to Julie? Okay, Julie agreed, Julie, he said carefully. So we'll move on then to the Foundation Group Subcommittee of last week. Julie, anything you want to add to this?
Again, just for the board to note that there'll be 2 reports in March around shared services, and we agreed 2 new joint areas of work, which was around information services and best practice approaches to prevention as a group, which again is really important that we take a consistent approach there.
No, that's great, Julie. Any questions to Julie on that? Super, thank you very much. And then we got the Quality Assurance Committee of the 30th of November and the Audit Committee of the 24th of November, just for noting. Any other business, colleagues? Please raise your hands. Okay, thank you. So we've got, I think, 2 questions from Councillor Contecourt that I'm aware of. Sarah, could you ask those questions that we've received, please?
Thank you. So the first one is the various vaccination programmes are so welcome and are the best route to save lives from both the direct and indirect impacts of COVID. Is the hospital correlating COVID test results for staff and admissions against COVID vaccination date to give early indications of vaccine effectiveness timeline? Also, are you already seeing less cases in your staff after your vaccination programme? I think Gertie is going to start to answer this question.
Thank you, Gertie.
Thank you, Chair. I've already picked up that we started the vaccination programme here at the George Eliot on the 4th of January, and the first dose can take up to 21 days to develop its full efficacy. The second dose, because it's an AstraZeneca vaccine, is delivered 12 weeks thereafter. The delivery model and the timescale between the vaccines is a matter of national policy, and the Trust continues to follow the national guidelines and the JCVI priorities in terms of the delivery of the vaccination. What I would say is that as yet there is not sufficient clear data on the impact of the vaccination programme, either here or in other organisations, to be able to fully understand its impact. The George Eliot is supporting the longitudinal study, which is the SIREN study, and we are encouraging all of our colleagues and those who come through the vaccination programme to sign up and become part of the SIREN programme, so that we can not only understand the virus itself, but the impact and the efficacy of the vaccine. I think it's difficult to say if there's any correlation or review in terms of patient numbers. What I will say in terms of staff absence, David has already covered the significant pressure we are under, but it is worth noting that a good proportion of that absence is related not to COVID itself, rather self-isolation, and that is that our staff are following what we ask them to do and staying at home and isolating until they have received a test. So through that, they are caring not only for themselves and their families, but our patients in the community. So I think it's probably too early yet to say at this stage in terms of impact or decreasing percentages of absence or loss.
No, I think spot on questions, so, and obviously that analysis needs to be done as we get more data. Glenn, is there anything you'd like to add?
Yes, it is a good question. And the SIREN study that Gertie referred to, as I understand it, there should be some report back from that in the next few weeks, which will talk about how immunity changes over time, which I think are quite positive. What I would say in terms of a positive impact of vaccination is the positive impact on morale of staff. Those involved in delivering the vaccine service have been clearly very positive. Obviously, those on the receiving end of it, it was good to see NHS staff prioritised, and that's gone down very well with the workforce.
Yeah. No, thank you, Glenn. I shouldn't, but I will. If any other members of the public who are on the line want to ask a question, please raise your hand. David?
Russell, I think there was a second question from Councillor Condorcet.
I apologise, David, if you can just hold. Sorry, Sarah. And the second question?
Thank you. So Councillor Condorcet is disappointed that the hospital has totally failed to consider pedestrian and cycle access to the site before putting in planning application for the vast extra care housing block. Many people access your site via the yellow bridge over the A444 or via the pedestrian crossing on College Street. Cutting off both these is totally unacceptable. Will the hospital add high quality walking and cycling access to the north-east side of the hospital site? And I think Hack's going to answer this one. Thank you.
Yeah, thank you, Sarah. I spoke to Councillor Condorcet earlier on today, so I'll summarise the discussion that I had with him. So the first thing to say is what we've submitted is an outline planning application, so it doesn't show all the detail of the access routes. What I'm able to do is commit to maintaining pedestrian access from College Street, and we believe that's really important to do that, and we can commit to doing that. The second point is that we are working with Warwickshire County Council on the highways improvement to College Street and the Bullring, which will include the addition of a cycle lane on our land, which we are again very happy to support. And depending on exactly how the new junctions are designed and the route design, that will then determine where we route our access, which is why it's not those accesses aren't shown on the current plans. And the final point is that as part of our sustainability and green travel plans, we are looking at developing or improving our cycle facilities on site, so secure cycle storage as well as shower facilities for staff as well, who we can then encourage to cycle more to work. So those are kind of 3 key points that I discussed with Councillor Condacourt earlier on, and he was happy with that response and wanted that recorded here in the minutes.
Thank you very much, Hag. And then David Carr. David, if you're speaking, we can't hear you.
How's that, Chair?
I can hear you now.
Etiquette of the meetings, I forgot to switch it back on. Chair, just like on behalf of the George Eliot Patients Forum, to associate ourselves with the words of Russell with the passing of Michelle Norton. What a wonderful matron, chief exec, director of nursing she was, and she will be sadly missed. And of course, all the words that have been said about the whole of the staff at GH and the tremendous work that they're doing at the moment under such pressure. I'd just like to comment, Glenn asked for a word of caution on the table that was published, I think, yesterday about hospital-acquired COVID cases. And I guess it was a snapshot in time, and therefore all the hospitals that are above us, the same word of caution should apply to them. So the George Eliot achievement of being third best really warrants merit and attention. But of course, along with that, I must say that second best was our partner in the trust, and that was South Warwick's. So between the two of us, I think we did an incredible job. And as you say, a word of caution, but a snapshot in time. Thank you.
No, thank you, David, and thank you for your kind words. Ladies and gentlemen, we'll therefore bring this public meeting to a close. We look forward to seeing you at the next board meeting, which is on the, just got to check my dates, which is on the something of March. Thank you. So we look forward to seeing you digitally again then. In the meanwhile, can I say to executive colleagues, we will have a 10-minute break and we will start the private board at 3:30. But can I again thank those members of the public who have joined us today. We do appreciate you giving up your time to get the update on how your trust is performing. Take care. Please continue to practice safe distancing, wash your hands, keep space and wear a face mask. Thank you very much. Bye-bye.
Thank you. Bye, everyone.